Our next speaker is Mia Yang, and she is from the Wake Forest School of Medicine. She's assistant professor and director of the Wake Forest House Call program. And the title of her talk will be Home-Based Medical Care for Persons Living with ADRD.
Thanks, everyone. This is a bit of a switching of gears from our previous speakers. I have absolutely no equations in my presentation. Missed that memo. And thank you for the introduction. Honored to be here today. I'm a practicing geriatrician, and I'm also a part of our Wake Forest ADRC. So today I will be talking more specifically about home-based medical care for persons living with dementia. And I'm having some difficulty advancing. Oh, here it is. Okay, I have no relevant financial disclosures, and these are my current funding, mostly clinical trial related, which I am not talking about in my presentation today. So in talking about the outline for today's talk, I will first define homebound and then talk in more detail about NHATS, the National Health and Aging Trend Study, which Dr. Quiones had mentioned earlier this morning. We'll look at this database and some of the associated research into the overlap of those who are living with dementia and those who are homebound. And then we will talk more specifically about home-based medical care or home-based primary care as a model of care specifically for folks who are homebound and or living with dementia, and then end on some future directions, both in general and then my own personal interests. So according to Medicare, Medicare defines homebound as someone who must need some sort of assistive device, such as a cane or a walker, or the assistance of another person to leave the home, or that they have some sort of medical contraindication. If a Medicare beneficiary does not fit either one of those criteria, then leaving the home has to require taxing effort, and that they're not normally out and about driving themselves around. And this is important in terms of Medicare coverage of home health services. And this is a reason why I wanted to talk a little bit about just an overview of home care, because home care is really an umbrella term and can be very confusing both for the general public as well as for researchers and clinicians. There are really three major buckets of home care. When my patients say, grandma needs home care, a lot of times they're really thinking about what Medicare considers to be custodial care. And this is really the care that is provided by a non-licensed person, such as, sitting with someone with dementia for a couple hours a day, providing meals like housekeeping, activities to keep them engaged in the home and this right picture. And based on my prior definition of homebound, that's when Medicare says if you're homebound, you can get paid for skilled home health services. And the skill part means that it's a licensed professional, such as a registered nurse, a physical therapist, an occupational therapist, social worker, speech therapist. Those are the folks who can come to the home, usually after a hospital admission, but it does not have to be associated with a hospitalization. And then what I will talk about today, and these circles are not to scale, home-based medical care, which is a very small component of home care. And this is really ongoing medical care that is provided in the home, and really what you think of as the old school doctors who carry their black bags and go into the patient's home and seeing them in the home. And home-based medical care is really the rarest type of home care. And that at different times, a person with dementia or without dementia may need all of these home care services or only some of them. And the way that the care is provided is really not only depending on on a person's function, but also dependent on who pays for what type of insurance they have, whether they have both Medicare and Medicaid, as well as the amount of family support. In our country, in America, Medicare really does not cover for custodial care, and a lot of that is really covered by Medicaid, which differs depending on which state you live in. So as I mentioned, the function is really important in terms of the site of care, and some people, most people proceed from their individual homes into some sort of assisted living facility, and then finally into a nursing home type of care. And function is only part of the equation. As I have mentioned before, there's a whole lot more people who are dependent in either their instrumental activities of daily living or their activities of daily living, but are living at home rather than moving into a facility. And for those of you who are not familiar, instrumental activities of daily living are things like driving, managing your finances, some of the higher order things we all need to do to be an independent adult, versus ADLs are really the personal grooming activities that tends to be impaired later in persons who have dementia. And a person living with dementia may or may not transition out of their home, really depending on their family caregiving situation, how much money they have, whether they have long-term health insurance, whether they can afford to move into an assisted living, which makes studying dementia in the home somewhat challenging. So next, I'm just going to transition to talk about the database that we can use to study both folks with cognitive impairment as well as their trajectories of functional impairment over time. So as Dr. Kionis mentioned this morning, NHATS is a nationally representative survey of older adults who are Medicare beneficiaries, and that there is a sister survey called the National Study of Caregiving. And this is an annual in-person interview that was started in 2011, and that it is really geared toward studying late life disability trends and trajectories. It is a representative sample of folks who are in the 50 contiguous states and oversamples racial ethnic minorities as well as the oldest old. Every year, the interviewers of NHATS collect information about physical, cognitive, and functional information, any sort of assistance, whether that's a person or a device or home modification to help with one's daily activities, as well as economic status. You can also link NHATS with Medicare claims data, and that if a respondent within NHATS says that they have a person to help with their daily activities, those caregivers are then enrolled in the National Study of Caregiving, or NSOC. And this can be a great database to study those who are homebound. So NHATS homebound categorizations are slightly different from the previous homebound definition I described by Medicare, but it's similar. So this is really based on the mobility questionnaire found within the annual NHATS study. So it's asking respondents how often they left out of the home. And if you never leave the home or rarely leave the home less than 1 day a week, then you're considered to be either mostly or completely homebound. If you were able to leave the home but needed some sort of assistance, whether it's with another person or had difficulty, then you're considered semi-homebound. And if you can go out by yourself with no difficulty whenever you would like to, then you're considered non-homebound or independent. And there are estimated 2 million Americans who are completely or mostly homebound based on when this cross-sectional data was analyzed in 2000, based on the 2011 NHATS data. So next, we're going to look at how NHATS categorizes cognition. So NHATS collects both subjective and objective cognitive tests. Subjectively, it asks the person who's responding, as well as the proxy, to report whether or not anyone has ever told them of a diagnosis of dementia. But we know that dementia is not only underdiagnosed, but also relayed to the person who is living with dementia. So the proxy could also answer questions on the respondent, the person who is being sampled within NHATS, by reporting dementia-related behaviors, as well as a measure called the AD8, which are really 8 questions related to how well they're functioning independently. Objective tests include a short-term memory, a 10-word median delayed recall, orientation to time and the president and vice president, and then some executive function and visual spatial function with the clock draw. And this table really just shows kind of who is asked to participate in both the subjective and objective measures. So based on the data that's collected here, NHATS categorizes dementia into really 3 different categories. There is the probable dementia category, meaning if a proxy or the respondent has reported to the interviewer of NHATS that they have a diagnosis, which probably rare compared to the actual people who have dementia. They must score a 2-point or higher on the AD8, which is administered to proxy, or that a person, the respondent, has less than or equal to 1.5 standard deviations below the mean in 2 of the 3 objective cognitive domains. For those who are categorized as having possible dementia, they have only 1 out of the 3 domains as less than or equal to 1.5 standard deviations below the mean. And if they do not fulfill any of those criteria, then they're classified as cognitively normal. And compared to a consensus panel for example, in the ADRC, to diagnose patients using quite a long, in-depth clinician interview and cognitive tests that last a lot longer than an NHATS. The NHATS battery still has a pretty good sensitivity and specificity, especially if it is for the narrow definition of probable dementia. So now we're going to talk about some data that uses NHATS to describe the homebound demographic. And this is going back to the same paper that I mentioned earlier that really looked at the definition of homebound within NHATS. And this is really the characteristics of those who have been categorized as non-homebound in the first column, semi-homebound, and then the homebound. It's the same table, just a little bit enlarged. So not surprisingly, folks who are homebound are older in age. They tend to be more women, and they have more racial, ethnic diversity in the sense that non-Hispanic Blacks and Hispanics represent 12% and 15% of those who are homebound. They are, not surprisingly, also have more multimorbidity in terms of as you progress to the homebound category. They are more likely to have depression, scoring greater than or equal to 3 on the PHQ, or the Patient Health Questionnaire, and that based on the NHATS cognitive, subjective and objective reports, the categorization of probable and possible dementia, 62% of those who are homebound fit the criteria of having probable or possible dementia. And not surprisingly, this also relates to functional dependencies as well, both in terms of ADLs, which is the self-care activity dependencies, as well as IADLs, or instrumental or household activity dependencies. As people become more homebound, they have more functional impairment as well. And we know from prior data, existing literature, that the folks who are utilizing healthcare the most are not only folks who have multimorbidity, but also folks who have multiple functional impairment, and mixed within that, a high percentage of folks who have both dementia as well as depression. And this fits clinically with what I see as well, treating our patients in the community who are homebound. My panel of primary care patients in the home are definitely more racially diverse than my clinic population. So homebound is really a proxy for complexity and a highly vulnerable group. Being homebound is an independent risk factor for death, and that what can be surprising is that if one is mostly homebound, their 2-year mortality is really 40%, which is really quite significant compared to some of our cancer survival rates. And this is, I think, a sign that being homebound is, a complex proxy that includes not only medical complexity, but also social complexity. And oftentimes, the homebound status reflects the later stages of dementia as well. So as we talked about earlier, there are these 3 general categories of homebound, semi-homebound, and independent, but in reality, people probably move in and out of these categorizations depending on what time of the year the NHAT survey is being conducted. But specifically, when we think about folks with dementia, once they become homebound or semi-homebound, generally that's a permanent disability because of their disease. And that's why home-based medical care can be particularly beneficial for folks who are more permanently homebound. So when we look at the folks who have probable dementia within NHATs, and if they're homebound, 48% of those who are homebound also have probable dementia. Among those who are semi-homebound, 26% have probable dementia, and then only 6% of those who are independent have probable dementia based on the NHATS categorization of cognition. So transitioning a little bit now to home-based medical care, what is it? It's actually a model of care that has been around for a long time, pretty extensively within the VA. They serve more than 59,000 veterans per year, and only recently has been increasing in non-VA settings. But as I mentioned in the previous slides, it's still the most rare type of home care, and it typically targets multiple chronic diseases. It's longitudinal, oftentimes interdisciplinary, meaning not only a physician or nurse practitioner, physician assistant, but also relates to nursing, a lot of cross interactions with home health agencies that deliver those skilled home care services, as well as social work. Depending on which program it is, they may have different compositions of what's in that team. And in different home-based medical care programs, the prevalence of dementia really can range anywhere from 35% to 60% based on the literature. And it's also reflected in clinical practice as well. In our Wake Forest House Call program, our percentage is actually 50%. Half of our patients living in the community have a diagnosis of dementia or Alzheimer's dementia related diseases, and the other half do not, but probably a lot more fit in that category of possible dementia, someone who might score lower than norms, but don't necessarily have a cognitively associated functional impairment. And although home-based medical care is pretty rare, there are multiple studies showing that They reduce hospitalizations, the total cost, as well as delay long-term nursing home institutionalization compared to matched cohorts who are receiving ambulatory outpatient primary care. Now, the exact reason and the mechanism of why home-based medical care can do all these great things is not necessarily well elucidated, because each of the home-based medical care programs may differ depending on what type of patients they serve. But I do think that this relates back into sort of a comprehensive person or family-centric care, where you're not really going into the home just to treat one disease, but you're looking at the person in its totality. And that when you go into a home, is oftentimes a lot more efficient to note any sort of change in their function or in their home environment that can take a lot more longer to notice if they came to the office to see me as a clinician. And all home-based primary care programs generally have a very strong overlap with home-based palliative care as well, just because once the patient becomes homebound, it's much more difficult for them to leave the home to seek specialty care or very invasive procedures. So despite the fact that most veterans who are enrolled in home-based medical care show very high satisfaction, and the fact that this model has shown benefits in terms of saving costs, not at the expense of lower quality of care, it is still very underutilized. So how underutilized? We looked at this using NHATs as well. So among those, even among those who are homebound, only up to 17% of them have ever received home-based medical care. Not surprisingly, that percentage is a lot lower if someone is not homebound or left the home but just had difficulty leaving the home. And a lot of who gets home-based medical care may be regional as well, because there are more house call or home-based medical care practices in certain geographic locations of the US compared to others. And when we look at folks who have dementia, even if they have dementia and are homebound, according to NHATs, it's still only 14% of those who have dementia have received home-based medical care. So this is interesting, and it leads to some fascinating future directions, including, I think this is a really great time to study home-based medical care and home-based care as a potential intervention for those who have dementia. We assume that this may be particularly beneficial for those in later stages of dementia because they are also homebound, but we don't actually know whether healthcare utilization, admissions, neuropsychiatric symptoms, or time spent at home is any different for folks who receive home-based medical care compared to traditional ambulatory outpatient care. We think that receiving this type of care in the home can also help relieve caregiver burden, but there really isn't any current literature showing that. And I'm also interested in how to disseminate home-based medical care for the homebound beyond the VA, and reasons why this particular modality of intervention is so underutilized. So I'm interested in studying really the implementation of home-based medical care, specifically for folks who are living with dementia. So here are some additional resources, and has some great video tutorials about how to use the data set, and I'm happy to answer any questions.
There are no questions in the chat or the Q&A, but maybe there are.
I have a question. It's Florence Johnson. Thank you for the presentation on home-based medical care. I've actually been talking about this as far as dementia care goes and supporting family members. So my question is, do you look at the person who's living with the dementia as well as their care partner when you go into homes, and do you kind of treat them like a dyad when you're there?
Yeah, excellent question. I think I'll answer this question as a clinician and not so much as a researcher, and I'll tell you why. When I go into the home to look at the person with dementia, I'm oftentimes I routinely ask about caregiver burden and ask how the caregiver is doing, because their ability to remain at home, which for most people is where people want to live, is highly dependent on how the caregiver is doing in terms of their own medical issues and their own health and stress. It's not uncommon for me to take on both of the spouses as my patients, because the caregiver is also having difficulty accessing traditional ambulatory primary care because they're always in the home taking care of the person living with dementia, particularly if they're at the severe stage or sometimes even the moderate stage if the neuropsychiatric symptoms are quite severe. From a research perspective, this one gets a little bit interesting. Outside the context of NHATS and NSOC, it's actually really challenging to study, and you may already know this since you're posing the question. It's really challenging to study the caregiver and the patient as a dyad within our healthcare system because we don't routinely link folks and mark them as a caregiver for someone else within our healthcare system. That's one thing I'm interested in tagging within our own electronic medical record, but it is challenging. I think there's definitely opportunities to study the dyad within NHATS and NSOC because they are linked by the design of the survey, that the NSOC participants are the caregivers for the people in NHATS. So I think there's ways to look at that, but I haven't had the opportunity to do so.
All right, one last question. So speaking of NHATS and how it's associated with NSOC, the caregiver study, are the caregivers interviewed annually just as well as the participants in the NHATS?
I think so. I haven't done a lot within the National Caregiver Survey, but I think they're interviewing the same frequency because there's really sister studies of each other and both are out of Hopkins.
Well,
Thank you.
thank you. I think in general, what we should be doing is sort of exchanging ideas as through the publications that we have. And I've personally taken a lot of notes today, articles to look up.